early 2000s, open hysterectomy through midline incision was the standard surgical treatment. Some retrospective data indicated benefit for laparoscopic hysterectomy. As a consequence, we conducted a prospective randomized trial, the LACE trial, LACE standing for laparoscopic approach to carcinoma of the endometrium. The first data of the LACE trial focused on quality of life and surgical perioperative outcomes, and they were very much in favor of total laparoscopic hysterectomy. What we did not know is how total laparoscopic hysterectomy would do with respect to disease-free survival. The LACE trial was designed as a non-inferiority trial with a 7% non-inferiority margin. We required to enroll 755 patients, and it was required that we enroll for 60 months and follow up for 4.5 years. So the initial outcomes, again, were very much in favor of laparoscopic hysterectomy in terms of surgical adverse events and quality of life. And the quality of life was even favorable for TLH after 6 months of treatment. Now, the more important part, though, is how is disease-free survival coming together? And the data that we presented here at this conference has shown that the disease-free survival curves overlap. There was no difference between the disease-free survival probability of total laparoscopic and total abdominal hysterectomy. The hazard ratio was 1.03. The pattern of recurrence was very similar, strikingly similar, as was the overall survival. These data have shown that patients who receive a total laparoscopic hysterectomy do not do worse compared to patients who have a total abdominal hysterectomy. And given the favorable outcomes of total laparoscopic hysterectomy in terms of surgical adverse events, quality of life and cost, and similar disease-free survival outcomes, we believe that now total laparoscopic hysterectomy should be made the standard treatment for endometrial cancer surgery. And in future, all treatments need to be measured against total laparoscopic hysterectomy also.